Here we go. So I'll be talking about the impact of supervised exercise on delaying the decline in cardiorespiratory fitness in men with non-metastatic prostate cancer. So basically the EMBARK population, if you will, of BCR in men treated with ADT and an ARPI, specifically enzalutamide in our EXTEND study. And so just a brief outline, I'll focus a little bit more on the background and rationale since this is a little bit of a different study than I think we're all used to seeing. And I'll get into the randomized controlled trial, specifically design and endpoints, results, and then end with implications and next steps. So it's already been discussed this morning, some of the side effects of ADT, but our concern is that the ADT can really accelerate the development of frailty. So if you look at the Fried criteria for frailty, there's really overlap with the side effects of ADT, such as decreased muscle strength and physical performance, increased fatigue, changes in body composition, such as increased body fat, decreased lean body mass, et cetera. And you can see this in the photos from the case study at right of two identical twins, one of which on the left was just diagnosed with prostate cancer, about to start ADT, and on the right, who had finished 12 months of ADT. And importantly, exercise can mitigate many of these ADT treatment-related adverse events. And so, again, our concern was we were seeing ARSIs, ARPIs approved in earlier disease states, as you can see in the timeline there on the upper right. And just to pick one controlled trial, Dr. Sternberg's study in non-metastatic CRPC, we saw numerically higher rates of falls, fatigue, hypertension, and cardiovascular death. Not to pick on enzalutamide, this is probably a class effect and has been seen across multiple randomized controlled trials. So our concern and really the rationale for this study was ARSIs are being used in earlier states of disease for longer periods of time. And so we were worried that earlier and cumulative effects may accelerate physiologic decline. And critically, these effects may not be fully captured in CTCAE reporting in clinical trials. And so we sought a better measure, what we thought was a little bit more of a sensitive measure for changes in cardiorespiratory fitness. And so what this is showing you in the upper right corner is a gentleman undergoing a cardiopulmonary exercise test, or CPET, on a bike. You could also do it on a treadmill. And so what we liked about CPET and cardiorespiratory fitness is it really integrates all of the body's system and shows you how a specific person can deliver oxygen to working skeletal muscles for ATP resynthesis. And so to focus your eyes on the graph at right, what is VO2 peak? What are kind of the important aspects of it? This is showing you a landmark meta-analysis published in 2000 of about 14,000 men from 242 individual trials. The investigators classified men into endurance-trained, active, and sedentary. And you can see the different lines. As you would expect, endurance-trained men have a higher VO2 peak. But importantly, VO2 peak is inversely related to age, and the rate of decline was independent of which group they were in. So it declines about 1% per year with normal aging. And so you can see frailty is somewhere around 14 or so milliliters per kilogram per minute. And so what we were concerned is with treatment with ADT and ARSIs, that those lines may be shifted down and men may hit frailty a little bit earlier than they would have otherwise. So this is the study design. We took men with non-metastatic castrate-sensitive prostate cancer. Men underwent baseline assessments. So this was specifically a CPET for VO2 peak, 1RM. We then randomized men to either get enzalutamide ADT with or without usual care. And critically, there was a lead-in period of 4 weeks in both arms, but in the exercise arm, this was really to allow men to get habituated to the results of exercise without experiencing treatment-related side effects. So a little bit of word about the exercise program. This was kind of the gold standard of exercise programs. It was centrally administered by Dr. Jones and his lab. And it was individualized for the patient based on their physiologic data. So their VO2 peak, their 1RM. It was 3 times a week for 16 weeks. So 48 sessions with one-to-one supervision, vital sign monitoring, et cetera. And so these are the objectives and endpoints. And so we picked, again, VO2 peak as our primary endpoint because it is correlated with all-cause and cancer-specific mortality in a number of different populations, including prostate cancer. We also looked at some objective assessments that may be more practical to administer in the clinic, as well as some of the primary physiologic determinants of VO2 peak, like 1RM. We also looked at PROs and safety, feasibility, and acceptability. So getting into the results, these are the baseline characteristics. And I'll just say here, these are the characteristics that you would expect from this kind of a BCR embarked population. There were no statistically significant differences between groups. And the relative VO2 peak based on age and sex normative data was exactly at the 50% for men. Notably, the study did close early. You might have seen we wanted to enroll 56 patients. We only enrolled about 26 over 2 years. And so by mutual agreement with the sponsor, we closed early. But so here are some of the important results. So focusing on the red, we're looking at the usual care group. So we did see declines, statistically significant declines in absolute VO2 peak and relative VO2 peak. That was paired with worsening of fatigue and quality of life. Whereas in the green, and I'm sorry that is not displaying, we did see improvements in some of the parameters, specifically the leg press and the 6-minute walk test. And then this is showing you the primary endpoint at left. So in terms of the improved absolute cardiorespiratory fitness in the exercise training group versus usual care, we also saw improved leg strength and improved functional capacity. This was based on ANCOVA of adjusted for baseline values. So getting into the implications and next steps to close out, this is the first trial demonstrating a clinically significant decline in cardiorespiratory fitness in patients initiating ADT with enzalutamide. And importantly, there were no trials looking at this, even in patients initiating ADT when our trial was initiated. In our usual care group, we saw the decline in absolute CRF after just 12 weeks of treatment approximated the decline seen with a decade of normal aging. And we can improve that with short-term exercise. We also showed we can improve 1RM leg strength and 6-minute walk distance. And I think this is particularly relevant in the EMBARK era. So we're undergoing efforts to screen our clinic and to try to scale exercise, specifically with home-based programs with a collaborator at UNC. So with that, thank you, and I'll just acknowledge my key collaborators and Medivation and Stellus for funding. Thank you.